Good afternoon, and thank you for coming to Medicine Grand Rounds. It's a great pleasure to address the department and divisions actually as a speaker rather than the chair, talking about chair things. I do want to talk about one component of structural heart disease that has had some significant changes over the last 2 decades, and hopefully share some ideas and approaches about how this group of individuals should be approached. This is particularly important today with the advent of our stroke center. I know that here with that, we're going to have a larger number of patients in whom we'll be asking questions about how to treat. And so today we're going to focus on the end part of that treatment, PFO closure, but we'll begin by thinking about how we identify the patients who are likely to benefit. My disclosures are shown, nothing that's really pertinent to this discussion. What we are going to talk about are an understanding of PFO development, talk a little bit about the mechanisms of cryptogenic stroke. We will discuss the trials, of which there have been several that look at PFO closure compared to medical therapy. There are some rare events that I want to make sure that we touch on. We'll talk about how we would develop a plan of care for patients who present with cryptogenic stroke. At the end of this, I hope that you have a better understanding of what that represents and who may or may not benefit from additional therapy. Let's talk about a real case. This last weekend, I actually had a 50-year-old friend of mine on a flight who called me from London, and I almost thought about using his information, but this is similar. A 43-year-old gentleman referred by our neurologist and who presented with right-sided upper extremity weakness that lasted 45 minutes. However, had no residual defect. He did have imaging. He had no CVA by MR, no residual deficit by neurologic exam by a neurologist, not by me. We know that that's a much better test, having a neurologist do that. Had not had any evidence of atrial fibrillation by history, 48-hour Holter, had a normal hypercoagulability workup, and otherwise was a high risk in that he was an airline pilot, certainly not somebody that we would like to be having a deficit while we're on a plane. Particularly if we're on an international flight. He was an international pilot, so even farther away, and really had no other medical problems. And those become part of our discriminators when we talk about who's at risk and who's likely to benefit. Some facts about cryptogenic stroke. PFO-related strokes, i.e. those that are due to paradoxic embolisms, have been strongly implicated as possible causes. I will say it's very difficult to demonstrate the causality rather than a association. Our epidemiology colleagues always want to point that out for us. In patients who are age 20 to 54, they are in a larger percentage of stroke patients, and among the first ever strokes, they represent an increasing percentage as well. Post-stroke psychiatric trauma disorder, what I've named PSPTD, is real and is important. If you've had one of these events, even if they were transient, your concern about that event does result in a traumatic disorder that influences your life and influences your choices. And it can, because of age, have that result over an extended period of time, much like other causes of post-trauma disorders. The other point to remember is that the cost of stroke is significant in the younger patients and is magnified by their expected life expectancy and loss of productivity and the need for long-term care in many of those. Another case that I thought of presenting was our 32-year-old nurse from our clinic who suffered one of these events as well. And you can imagine how devastating that is as a young nurse or a young healthcare professional to have an event like this that occurs. We want to be patient-centered in our approach, and we want to begin to think about the clinical events or incidental findings that may have resulted in embolism. We have a first-line diagnostic workup for causes of embolism so that you want to, and we'll talk a little bit more about that, think about why somebody might have had an embolic event outside of a structural heart problem. Did they have hypertension? Did they have coronary artery disease? Do they have atherosclerosis? Do they, in fact, have a hypercoagulability profile? There are a long list of reasons why you can have a cryptogenic or otherwise undetermined etiology of an embolic event or stroke. And if you have definite causes, that is, if you had a left atrial thrombus, of course, you wouldn't proceed with further workup. In those patients in whom it's uncertain or no, then further diagnostic workup looking for a PFO is indicated. And for those of you that are involved in the stroke project, you know that one of the early definitive tests that's done, in addition to CT scanning of the head, is an echocardiogram looking for the possibility of a PFO. And so whether or not you have a PFO is present and making sure your approach, and if it's a cryptogenic embolism, then you want to know if it's PFO associated or not. And then the likelihood, whether it's causative and what the risk might be for that. So what is a PFO? A PFO is failure of the septum to close. So as the premium is developing, you can see here that it comes down. You can see this en face and on side. It fenestrates in at the area of the foramen ovale. The secundum is inferior to that. The foramen ovale is superior. And you can see that failure of this to actually firmly adhere is the mechanism. It's a frequent mechanism. One point I would make is that it can be associated either with fenestrations, incomplete dissolution of that membrane, or it can be associated, in fact, with a true secundum defect. And so as individuals who begin to practice closure, you have to understand that multiple defects can, in fact, be in place. An echocardiogram shown here, and we'll talk about that a little bit. You can see the aorta in the center, the interatrial septum here, right atrium, left atrium. Notice on the bottom left this separation that occurs right there. And this separation, this tunnel, is in fact what we're referring to. So we talk about a patent foramen ovale as being a hole. It's not. It's a tunnel. And it's a tunnel demonstrated here that varies. You see, not every beat actually demonstrates that there, in fact, is flow. And that's true across the board in terms of the patient. We'll talk about that in some of the rarer symptoms and findings. You can see on the right-hand lower panel agitated saline that's given, and this otherwise referred to as bubbles in the vernacular. Carbonation, perhaps better for patients. And you can see here a dense filling. That would be a high level of communication that occurs. This, of course, is what the archetypical thought is, and that is that you have this rope. You can see here what likely began as a DVT with a large thrombus that has the structure of a vein that now is working its way across the interatrial septum. A very uncommon event, but striking when it occurs, and represents why we believe that there are mechanisms. Now, strokes probably don't occur because of these long ropes. They probably occur because of smaller fibrin or platelet-rich thrombi. That appears to be the mechanism. Much more difficult to diagnose. Now, having shown you this, you need to be aware that in the non-stroke population, as most of you are aware, that somewhere between 10 and 25% of the population have, in fact, a PFO. In this room, there probably are 10 or 15 people that have a PFO. Does that mean you're going to have an event? Absolutely not. There are other incipient things that have to occur. We do know that the population that suffers cryptogenic stroke has an enriched number of patients who have a PFO. Again, is that causality or is that association? Unclear. You cannot take away that a cryptogenic stroke plus a PFO occurred because of a paradoxic embolism. You have to make sure that there are not other mechanisms. And one of those is a scale called the rope scale. Now, the rope scale, and the longer the rope, the more likely a stroke is related to a PFO, recognizes those comorbidities that are likely to be associated with a stroke. Hypertensive patients, brain small vessel disease, more likely to have a stroke. Diabetics, more likely to have a stroke. And you'll notice here the top part says no history. That means if you are a diabetic or hypertensive, have a history of prior stroke, or a smoker, have peripheral infarct on your CT, i.e. non-central, non-embolic, then it's a no to that. On the bottom is simply age. Not surprisingly, the older we are, the more likely we are to have a non-PFO mechanism, either hypertension or diabetes or atrial fibrillation, arrhythmias that we'll talk about. And so this becomes a useful screening tool to begin to estimate whether or not the patient that you're seeing may or may not have been someone who had a PFO-related embolic event. Atrial fibrillation is one of the most common associated reasons for that, and we've seen an increasing recognition of that. I'll talk about that shortly. But in your evaluation of individuals who have a CVA, no other etiology, we can use a number of pieces of data, 12-lead EKG in hospital telemetry, and as we get to that across our hospital-wide practice, that will be helpful. 24-hour ECG monitoring, all have been used. This is from the European guidelines, and if you detect atrial fibrillation, they would urge you to stop. I'll return to that in a second, but certainly if you have atrial fibrillation in a patient, treating the atrial fibrillation becomes an important first line. If you don't have atrial fibrillation, then you want to look and see if there is a PFO as the next most likely mechanism for that. Obviously, if you're young, middle-aged, or older, your form of monitoring is going to change. Certainly, if you're over 65, you may choose to do monitoring using an implantable device. And I'll show you the basis for that in a second. If you're very young, then you want to evaluate for major risk factors for atrial fibrillation. Again, hypertension, underlying known structural heart problems, not congenital, but LVH, or left atrial abnormality, whether or not you have undiagnosed or uncontrolled diabetes, underlying heart failure. Other minor things include obesity, what your atrial rate is, do you have underlying pulmonary or thyroid disease. So you want to understand the risk profile of that patient. The concern about AFib comes from this following study called Crystal AFib, demonstrated on the right-hand panel. And you can see that if you monitor patients with extended monitoring, subcutaneous monitors, as demonstrated here, that you can find in a population of cryptogenic stroke patients a significant percentage of individuals that have atrial fibrillation. But it may take out to 3 years. And the question is, if you had a stroke today and it takes you 3 years to find atrial fibrillation, which of those would you treat and at what point in time? An unresolved question. Some of it depends on how you look for that. So roughly 3% are going to have an admission EKG with atrial fibrillation. If you use the implantable loop recorder shown here, it may be 20 or 30%. But your clinical judgment becomes important in terms of, are you going to tell somebody that at a cryptogenic stroke, well, we need to monitor you for 3 years in order to find out whether or not we should close this PFO that I found today. That's a tough discussion to have. And so your interactions with the patient, often with the family, certainly with the other caregivers, is critical in making that decision. What about patients who have had a DVT? I showed you that example of that rope climbing through this foramen tunnel. It turns out that it depends a little bit on where you're looking at. And so this is a series from this last year in neurology, looking at 360 out of a 780 patient series, where they did look at whether or not they were hypercoagulable, and they separated into those that had a TIA and those that actually had evidence of an anatomic defect or stroke. And if you follow this down, they excluded a bunch of people. But the bottom line is that, and I didn't show it here, but you can see 10 out of 189 and 10 out of 780, a very small percentage of patients with TIA actually had a significant hypercoagulable abnormality. On the other hand, if you had a stroke, 13% of patients, 13%, actually had hypercoagulability. Now, one of the important features to remember about this is some patients will be hypercoagulable early on, and so you need to wait 6 weeks to 3 months before you test or at least retest, because 2/3 of these patients actually ended up testing negative when tested late. But in those that tested positive repeatedly, 13%. And so we cannot avoid looking for hypercoagulable states, particularly in these younger individuals with that other evidence. We do talk about the echocardiogram and depend upon that. One does not need to have a transesophageal echo. You can use a transthoracic echo, and it should be the first screening test. And what this illustrates is that the foramen ovale, again, is a tunnel. And you can see here the tunnel. We describe these for those people who are trying to make assessments by whether or not there is an aneurysm of the septum. I'll come back to that. We talk about tunnel width, tunnel length. You can see here that this is the fossa up here, and the septum secundum is down here. So this is a superior defect. This is what that tunnel looks like on a three-dimensionally reconstructed interatrial septal view, here on the two-dimensional views. So not all of the individuals actually will have that kind of separation, and it may vary a little bit about the situation. If you did a Valsalva in somebody, increased right atrial pressure, you may be more likely to have this demonstrated compared to a baseline. So our approach looks like this. Imaging should, as we talked about, in individuals who don't have a clear-cut reason for having had a stroke, particularly those that are less than 65. A transthoracic echo should be done. I'm a very large fan of using agitated saline because it increases your diagnostic accuracy a lot. From there, however, you may need to go on to transesophageal imaging, which could include intracardiac or transesophageal, and then intraoperative procedures if you decide to move to closing. You've heard me refer to shunt grading, and I want to discuss that with you because when you hear how large a shunt it is, if someone's not describing to you a grade or a number, then you need to use that because it does, at least in the early studies, have an impact on clinical outcomes. So shunt grading incorporates 4 grades. Grade 1 is less than 5 bubbles. Grade 2 is 5 to 25 bubbles within the first 3 cardiac cycles. And this is in 3 cardiac cycles. Grade 3 is 25 bubbles. Grade 4 is if you fill the entire chamber. Do remember that the agitated saline can go out to the lungs, through the lungs, and gets passed back through the left atrium and the left ventricle. So simply seeing these small carbonated structures does not mean that you have a intracardiac shunt. It could be an intrapulmonary shunt. 3 beats seems to be a good discriminator. If the filling occurs after 3 beats, then do be aware that it may be pulmonary. Now, it may be significant, and there are a number of patients that have pulmonary arterial venous fistulas that, in fact, present with systemic emboli because of failure of filtering within the pulmonary vasculature. And so large amounts of bubbles late should be your clue that there's something else going on, like an AVM, rather than an intracardiac shunt. The PFO procedure is relatively straightforward, assuming it's only a PFO, and that is one can pass a wire up into the left upper pulmonary vein. Over that, you can, although we do that less frequently today, use a balloon and measure the expanded width of that tunnel and the length of the tunnel. You then can cross with different devices. I'll demonstrate those. This is one that is a circular ring that is very soft and expands within that tunnel. Here is looking at it from the right atrial side, this ring en face in an echo. So it's something that can be accomplished in a cath lab. Is a relatively brief procedure, 30 to 40 minutes. The patients are up and ambulatory and go home certainly the next day. In some places, they may go home the same day. It is a permanent fix. So the likelihood of not having sealed that is very low. When we talk about PFO closure, we'll talk about really 3 devices, one of which is not shown here. This is the Amplatzer, which is a double wire ring expandable nitinol device. Think Slinky. So when you stretch it out, it's all long, and when you release it, it resumes this position. The other is the Gore device that has also nitinol, but a membrane PTFE material. The original evaluation was on this device called the Helix. The current approved device is the Cardioform. Basically, they're the same kind of concept. The Cardioform actually has much better performance characteristics. So what do the studies tell us? Well, we want to make sure that we're in bounds. I used this at a time when we started out that we had basically what was called an HDE, Humane Device Exemption, or Human Device Exemption categorization, which said, well, you ought to do about 4,000 of these a year. We really don't have enough of a market, so we're just going to start doing that. All good things. So here's a history of all of this, and you can see a couple of things that there was in 2000 an HDE approval of CardioSeal. By the time that you get to this enrollment, there were 80,000 80,000 procedures per year being done. Not 4,000, 80,000. And it was during that time that people said, wait a minute, we need a better understanding of exactly what we're doing. And it began with these trials with the Amplatzer device, that metal ring that we talked about, and trials. And then we had HDE approvals for the devices going away as we had data. And then we have a number of trials that we'll talk about in brief because they give us some information about this. So the PFO occluder is here. CardioSeal is the original device, and really was only used in one study. I'll demonstrate why. And then the Helix Cardioform evolutionary process, getting us to today where we have FDA and CMS approval. Here are the studies. You can see a long litany of studies, the most recent of which was the Defense PFO. It's relatively large numbers of patients when you look at this event, and so we'll talk about each of these in individual. So as we heard from Sherlock Holmes, I had come to an entirely erroneous conclusion, which shows, my dear Watson, how dangerous it is to reason from insufficient data. So I'm going to show you the data, and we'll see what reasonable conclusions we draw from that. Closure 1 used this Starflex device, and you can see it doesn't look like the other devices. It didn't function like the other devices, and it didn't close the PFO like the other devices. But other than that, it was a good thing to start with. And so this was 909 patients who either had a stroke or TIA, but you didn't have to do any imaging. They were randomized to anticoagulation or anticoagulation with the device. And the primary endpoint was pretty good because it was out to 2 years, but it looked at early neurologic events or death. And what you can see here is that while there is a separation in this population, it was not statistically significant, although the reduction by hazard ratio looked pretty good. The problem was the company sort of bet the ranch on this one. And so the company actually fell apart when they had a study that wasn't positive. But on the heels of that, recognizing what we saw from the other trials, Bernie Meyer, now using the Amplatzer device, looked at a 1-to-1 randomization, a smaller number of patients, looking at 1 to 6 months of antiplatelet therapy, not anticoagulation, but antiplatelet therapy. Or those patients could be on oral anticoagulation if deemed positive. And you can see here what is the beginning of our trials, which it says, G, from this trial, PFO closure once again shows us a trend towards, but not a statistically significant benefit. When you do the numbers, what you say is you really need that 900 to 1,000 patients to begin to show that. The other feature is notice that this separation occurs not so much at 1 year, maybe not even at 2 years, but you need to follow patients later. And that's difficult because what do we ask when we treat patients who have myocardial infarction or heart failure or cancer? We want to know in the next 6 weeks or 6 months how they're doing. We don't always ask how they're going to be doing at 6 years. But if you're treating, as we are here, 18 and 20 and 35 and 40-year-old individuals, that's part of the story that's important. So along comes RESPECT, again an Amplatzer PFO trial. Again, what you begin to see is a near miss. I mentioned the 1,000-patient trial, randomized 1-to-1 against either antiplatelet therapy in the majority of the time, looking at a primary event that is fatal ischemic stroke, non-fatal stroke, early death, which is a small number. And again, when you look at that, you see those patients who are closed have more event-free survival than those aren't. And now what happened is we said, well, let's look at the patients over a longer period of time and begin to ask that question. So it's very clear that in the first year or two that we're not seeing that kind of a difference. What we are beginning to see is a difference, and I won't go into the reasons for this, but there are a couple of methodologic reasons. But you can see here, particularly late, a significant continued difference in therapy. If we look at the reduced trial and ask questions about looking at all patients, everybody seemed to benefit, even older patients. Males perhaps a little bit better than females. One of the questions began, well, what about small shunt size versus large shunt size? I mentioned that earlier. Clearly, large shunt patients are the most likely to benefit. And when you look at sub-analyses, they benefit the earliest. The closed trial was Slightly lower numbers, but again, looked at PFO plus DAPT, short-term therapy, only 3 months, versus all other medical therapies, single antiplatelet therapy. Again, followed for 5 years. Not significant at 1 year or 2 years, but the continued benefit in these patients is they have a sustained difference and lower event-free survival if you had antiplatelet therapy only. And if you looked at intention to treat, those patients who were intended to be in the PFO group versus antiplatelet, again, the same sustained benefit from Sundergaard's group in Sweden. The most recent of these, again, looking at the same outcome, are Defense PFO group versus those that had closure. Again, something that takes a year or two to show a difference. Well, we're all familiar with pie charts. This is my favorite pie chart. It's the one that tells me the most. It's how much of the pie I've eaten, how much I haven't. But we know that individual studies may not give us the most important information. And so what do we see when we begin to look at PFO Meta Analyses? Now, I will say that there are, at last count, 23 meta-analyses of these 7 trials. Go figure that, right? I mean, how can you have that many meta-analyses from 7 trials using different numbers and different outcomes? But statistics. What I'm showing you, however, I think is one of the strongest from the American Journal of Medicine that came out and looked at the trials that I showed you. Defense PFO was not out at this time. It drives it even further when you see it. What is very clear is that all of these trials tell us that closing a PFO in the appropriate patient without other mechanisms is beneficial, and that the risk of reducing stroke and ischemic attack is significantly enhanced by closing a PFO as well. So that in patients without other mechanisms, closure of a PFO today is in fact strongly supported by the literature. If you look at subsets of patients, if you have an atrial septal aneurysm present or absent, we used to say you needed that big floppy septum changed the likelihood. It turns out it doesn't. So whatever your septum is like, it may change your procedure, but it doesn't change the risk. So ASA is off the list. Now, atrial septal aneurysm isn't part of the risk of these patients. What about shunt size? Well, clearly, if you look at large shunt being present, I showed you 3 of those trials. You can see here that, in fact, a large shunt is more likely to show that. A sub-analysis of defense calls this into question for small shunts. I think if you have a grade 1 or a grade 2 shunt, it is worth asking the question about whether or not you would actually run a risk by closing that patient at that time. Atrial fibrillation, if you stick something inside of the left atrium, do you not cause things to happen? And the answer is, you're not surprised to know you do, right? I mean, if you mess with the atrium, it's going to get upset with you. And so atrial fibrillation, in fact, because of irritation, does occur, and the likelihood of atrial fibrillation is pretty significantly increased in those who have a device placed versus those that don't. The question becomes, how long does that risk last, and is it important? So if you look at that, yes, we have an increased risk, but it's resolved within about 2 weeks in 2/3 of the patients. So it's transient while all this is going on. And of those that had Afib after a PFO closure, it's a small number of individuals who actually have an event. Is it a consideration? Absolutely. Absolutely. You don't want somebody having a stroke because you put a device in that resulted in Afib when you put the device in because they had a stroke. What about the effect of the device on recurrent strokes? Well, I've shown you this before, but to reiterate that the consistent hazard ratio is clearly in favor of those individuals who have closure of this compared to those that don't. Is there a difference in devices? There probably is. So I gave you the Starflex as the initial device, and the Amplatzer clearly has improvement in terms of risk reduction for recurrent stroke, Amplatzer versus Starflex. Gore versus Starflex better. Amplatzer versus Gore, there still seems to be some differences. That is not with the current Gore device. Afib, Gore, Amplatzer, some differences. If you're going to choose what's currently used today, Gore versus Amplatzer, probably doesn't make a difference. Let's talk a little bit about how many you have to treat. The absolute risk reduction per year with the device closure over medical therapy is 0.56. That means you have to treat about 178 patients. If you make this in large shunt patients, the number to treat for 1 year reduction is 96. I showed you that what's really important is probably not 1 year reduction. It probably is the fact that you now have a 5-year reduction and probably a lifetime reduction in these patients. And so it's more difficult to calculate what that number needed to treat is. It falls to about 1 in 18 if you start looking at the 5-year data. So for PFO closure, it's a single intervention. It has a low rate of complications. I didn't show that overall, but you saw that. It's under a 1% complication rate overall. Patients consider a stroke a worse outcome than death. You've all had that discussion with our patients. The particular patients we're discussing are young. They all have a good likelihood of making a recovery from their index stroke. And the number to treat at a single point in time does not reflect the large number of disease-free life years that we're likely to provide patients. And so as I'm thinking about this and having the discussion, what I want to know in a 40-year-old is how many more years are you going to have where you're not at risk and where you may benefit. What about those patients who have a documented DVT, and that number of individuals? Well, it becomes a decision about whether or not the DVT causes systemic embolization. So if there's a low uncertainty, you want to evaluate for either bleeding or risk of recurrence. You want to think about antiplatelet or oral anticoagulant therapy. If the individual is at high risk and they're in this younger age group, 65 for those of in the audience has become young, I like that. You want to have some shared decision making and consider PFO closure. So if the risk is high, atrial septal aneurysm, I told you, is off the list. It turns out even if you have a coagulation disorder, or perhaps when you have a coagulation disorder, closing that PFO, even though you have to be on anticoagulants for other reasons, has a benefit. And it has nearly the same risk reduction in recurrent stroke in the normal population. Other risk factors, again, older age, PFO size, stroke or TIA as the index event. I showed you those risks before. All of those need to be considered in your decision making. Let's spend a couple minutes talking about some special situations: systemic embolization, decompression illness, Platypnea-Orthodoxia Syndrome, migraine with aura, and I felt like I wasn't going to have time to delve too deeply into that, but we'll mention that. And simply say that we have done a large number of studies in migraineurs and been able to demonstrate a non-statistical but clinically beneficial decrease in the numbers of events, but not cessation of events. And so there currently is not an indication for PFO closure due to migraine. In fact, some patients who have a PFO closure transiently or for a prolonged period of time may develop migraines, not having had it before when you do close a PFO. Why exactly in terms of the mechanisms, it's unclear. But what about systemic embolization? Let's be clear that by systemic embolization, I mean it didn't go to the brain, right? Went to an arm or a leg or a kidney, someplace other than the brain. That's an unusual pattern, as we all know, but can occur. There is no randomized data that demonstrates that if you close a PFO in the case of an otherwise unexplained systemic embolization, that it decreases subsequent events. But it's an uncommon event. Finding 900 patients to randomize that had this event, we haven't been able to do. So we are called upon to make some clinical judgments, and I think that logic would dictate that closure might be indicated in highly selected cases. So if you had a young patient who presented with what you felt to be a coronary embolization, normal coronaries, no evidence of spontaneous coronary dissection, absence of other risk factors, then at least that should be part of the discussion. But we have no data to tell us exactly what we should do. Anybody here divers? Scuba divers? No? Couple. Okay. Got a couple folks. Okay. So for those of you who do dive, you are familiar with the tables and what decompression sickness is. For those of you that are closer to the coast dealing with workers, particularly those that are out on the decks and the docks out there, this is a big issue. And it turns out there's some other groups of people. I worked with airplane mechanics, and they actually did some stuff in suits as well. So there are a lot of of people in which this might come up. The presence of a right-to-left shunt, such as the PFO, allows nitrogen bubbles, just like the spontaneous contrast in that saline I showed you, to bypass the pulmonary bed. The occurrence of decompression illness, despite using decompression algorithms, implies an increased risk of right-to-left shunt, and you should investigate these people for a PFO. Diving profiles are designed to limit the time at depth and slowly ascend, so you diminish the likelihood of having nitrogen bubbles developing. A longitudinal, non-randomized follow-up study did demonstrate reduction in both symptomatic neurologic events and total brain lesions among recreational divers with PFO and decompression illness who then had a PFO closure compared to those who continued diving without closure. So we have anecdotal data that says if you are going to dive, that you really need to consider that, particularly if you're beyond 1 atmosphere. If you're under 30 feet, doesn't matter. And so you may have that question arise. Again, 1 in 4 people have a PFO. So that if you are a diver and you know that you're going to be down, particularly if you're going to be diving on mixes, then you need to have that considered. And so the other group are if you have a professional diver who wishes to continue diving, a PFO closure could be recommended. The other group are pilots, where they may decompress in a different way. And so when I was in San Antonio, we had a lot of commercial pilots and high-performance pilots. And so that's the other group we would consider doing the same thing. For the residents and other people, one of these favorite things we like to talk about, Platypnea-Orthodoxia Syndrome. What the heck is that? Has anybody heard of this before? Not many takers. Bashful folks in the room. Okay. So Platypnea-Orthodoxia Syndrome is rare, but you will see it sometime in the next year. Okay? It's not that rare that you don't see 1 or 2 cases a year. It's characterized by positional desaturation and dyspnea with individuals who have a PFO. What happens is that the geometry of the atrial septum is altered and allows continuous streaming of deoxygenated blood from the inferior vena cava across the PFO in certain positions. Most commonly, it's seen when you lie down. Talked about volume increasing the right atrium, volume in the right atrium, pulling the atrials, the PFO more open so that you have a wider opening of that tunnel when you have more volume. And so these individuals, seen when the patient's seated and the oxygen saturations are normal and the patient's flat. And it's because you get tracking across the valve in the seated position. So this distortion that occurs can be exaggerated by chest surgery if you have pneumonectomy, aortic dilation, so people that have hypertension, dilated aorta, if they've had prior aortic surgery, and occasionally you'll get a tricuspid regurgitant jet that's directed across the PFO. So somebody who is normoxemic lying and hypoxemic sitting is the characterization. So it's not actually related to underlying cavity pressures, may be related to volume, responds well to closure, and provided that you don't have pulmonary hypertension from it. And there's a group of patients that demonstrated that that could be done. So what should we be thinking about in 2019? In selected patients who have cryptogenic stroke, a PFO closure, as you've seen, is superior to medical therapy for the prevention of further stroke, both in the short term but more importantly in the large term, particularly true of those that have moderate to large shunts. Do be aware that this population also has an increased risk of atrial fibrillation, both as a cause but also post-PFO closure need to be surveilled. FDA has accepted this indication, and it's now both devices that I showed you are approved. Guidelines are being prepared in the U.S. In Europe, they've already adopted the guidelines. The Canadians have adopted guidelines reflecting this approval. So that's an introduction and overview of PFO. And I'll stop at that point and see if individuals have questions. There's more lunch for people that didn't get lunch up here. So thank you very much for your attention. So the question is, for those that you're concerned about a PFO and are being seen, should they have a bubble study as part of their evaluation? My answer to that is yes. It turns out that there is some conversation in the literature, but when I look at the data, it says there's about a 15% higher likelihood of an abnormal study if you're using, defining a PFO, if you're using agitated saline. And so,
I think our default in Epic right now, our default echo when they pull up 2D echo is not with a bubble study. They have to actually go and add that. So, but you would recommend that if we're working up an initial CDA and we're looking for causes, we don't have obvious cause, we're looking for cryptogenic stroke, bubble study would be your recommendation?
That's my recommendation. It's not a TEE, by the way. Yes. So transesophageal electrocardiogram should not be the default study.
Should it be for any CDA or just the group, this group of patients that as a younger patient, that we have so much cardiovascular disease in our dialysis.
Yeah, so
it's mainly from, arterial disease other than.
So the question becomes, who should have not an echo, right, but add the agitated saline? Because if you're thinking about this, right, if you're a stroke patient, what are the risk factors for stroke? And those were addressed. If you have LVH, left atrial abnormality, patients that you're discussing that are the dialysis patients are more likely to have those. If you have a wall motion abnormality, et cetera, so you're probably going to get an echo on every stroke patient no matter what. In fact, that's what the stroke guidelines say. But if you don't have those findings, don't have evidence of intracerebral pathology or carotid artery pathology, then you probably should be asking, either at the same time or subsequently, to go ahead and get an agitated saline evaluation. Yes?
The obvious hard endpoints in these studies were cerebrovascular events. Did they incorporate post-treatment bubble studies and correlate those with events?
Good question. So were there routine evaluations of the presence of right to left flow? The answer is no. There were sub-study analysis so they're aware of what the likelihood of residual shunt was. Residual shunt was less than 1% in the two most recent devices. But they were not a hard endpoint. They didn't bring them back. Defense PFO did bring them back for a routine shunt study, but the others did. Yes?
Curious, those patients that peri-procedurally did develop Afib after the procedure, if it was just transient with reduced complication rates afterwards, do you typically give them prophylaxis either with aspirin or anticoagulation or no?
Okay, so the question was for those that develop it immediately post-procedure or at some point?
I thought you had mentioned that some patients peri-procedurally in the next, couple of weeks had developed a higher rate of Afib.
So it's anytime in the next 6 months. When they have it, two-thirds of it only lasted for 2 weeks. The good news, I guess, is it is not likely to occur after 6 months. So thanks for making sure I clarified that. And most patients are treated, as you saw, either 3 months or 6 months of antiplatelet therapy after the device is placed. And we do that therapy because empirically we have decided, it's true empiricism, that there needs to be a time for the device to heal. In a pig, it takes 30 days. We translate that from other studies, meaning in humans it needs to be 6 months. There's a lot of argument about what that truly looks like. But empirically, we would treat somebody for 6 months. I didn't talk about SBE prophylaxis, but it is recommended that at least 6 months that these patients, and I go out to a year for SBE prophylaxis for an implanted device. Other questions? No? I'm going to give you back 15 minutes of your life.